Okay.
Okay, thank you, Adrian. This is this is Krista Taylor. I'm the president and CEO of Behavioral Health System Baltimore. Welcome to our very first GBRICS Council meeting. I'm really excited to be here. Today's a really, really big day. This has been a long time coming. It's a partnership that developed more than a year ago to write and submit the grant, and we've continued working together as a partnership to get us exactly where we are today. BHSB is a nonprofit that serves as the local behavioral health authority for Baltimore City. In that role, BHSB is a collaborator and convener of partners with their overarching goal of supporting behavioral health and wellness. GBRICS is a really important project because there are gaps in our service delivery system for behavioral health crisis response services. There's a need to be partnering with hospitals, and there's a need to be approaching system structures regionally. So my deep felt thanks for being here today and being a part of this very important project. I'm looking forward to our work together. I want to start off with a couple of introductions. First, the BHSB GBRICS staff, if you can take yourself off of mute and introduce yourself. And first, we'll start with Adrian.
Good afternoon, everybody. I'm Adrienne Bridenstine, the Vice President of Policy and Communications at BHSB.
Thanks, Adrian. And next is Kristen.
Hi, everyone. This is Kristen. I'm an operations specialist at BHSB.
Thanks, Kristen. And on his very first day of work, we have Daniel, if you want to introduce yourself.
Sure. Hi, everybody. Dan Rabbit, Policy Director for GBRICS at BHSB as of today. It's really good to be with you. My previous job was at Heartland Alliance, which is a large health and human service provider, behavioral health provider in Chicago, which is where I'm still located, but we'll be moving to Maryland in the next couple months as weather and pandemic permit, and can't wait to keep working with all of y'all.
Great, welcome. Happy first day of work. Next, we have Shauna, who is officially not starting at BHSB on the GBRICS project until March, but is with us here today. So Shauna, if you want to introduce yourself.
Sure, thanks for having me. I'm so glad to be here. I'll be the GBRICS Implementation Director, and I'm a clinical social worker with experience managing behavioral health case management, community health worker projects, and working with hospital systems. So I'm very excited to be part of this.
Great, welcome, and we look forward to you starting in March. And then our last GBRICS staff person is Lizzie. You want to go ahead and introduce yourself?
Hi everyone, my name is Lizzie Unger. I am the communications manager at BHSB, and so I'll be helping with some of the GBRICS communications as well. I'm happy to be with you all today.
Thanks, Lizzie. And then last but not least, not officially a staff member, but a consultant working with us and has gotten GBRICS to where we are today. Diane, want to go ahead and introduce yourself?
Sure. Hi, everybody. I'm Diane Stallenwerk, and I have a small consulting firm. I am based in Baltimore City. And my specialty, I guess you'd say, is multi-stakeholder collaborative work in the health policy space. And I've been involved with the GBRICS work from when it was a twinkle in people's eyes, and was able to help get the process together to design the program and then write the grant that eventually was approved and funded by HSCRC.
Thanks, Diane. And let's move on then to the GBRICS Council members. If you could, one by one, take yourself off of mute and turn on your camera if you can, if you have that technology, and say your name and your title and where you're from. I don't have a list, so we're gonna wing it and go one by one.
I'm Linda Rain, CEO of the Mental Health Association of Maryland.
Great, thanks, Linda.
Nikki McCann with Johns Hopkins Health System.
Dina Stout with MedStar Health.
Robin Mattermass with GBMC.
Andrea Brown, the Black Mental Health Alliance.
Maria Tilden with Care First.
Hi, everybody. Ben Launer. I'm Medical Director of the Baltimore City Fire Department. I do a lot of critical care transport and also a clinical emergency physician with the University of Maryland School of Medicine.
Angela Cooper with Mercy Medical Center.
Ryan Moran, Community and Population Health, MedStar Health.
Elizabeth Crom with Howard County General.
Mark Orlowski, I'm with the Howard County Police Department's Mental Health Section.
Carl DiLorenzo, Policy Director with Howard County Government.
I'm Katie Rouse. I'm the Executive Director of On Our Own of Maryland. We're a statewide peer-run behavioral health education and advocacy program. So I'm representing our local centers in the GBRICS region.
Chuck Callahan, I do population health for the University of Maryland Medical Center, and I'm representing University of Maryland Medical System.
Corey Hatchett from House of Refuge International Church Community and the Rosemont community.
Sue Doyle, Carroll County's LBHA.
Brian Hepburn, the National Association of State Mental Health Program Directors.
Hello, this is Stephanie House. I'm with Baltimore County Local Behavioral Health Authority, which is part of the Health Department in Baltimore County. Thank you.
I think that is it for our council members. Is that correct? Did we get all the council members? Okay, I'm not hearing anybody else. Adrian, I want to turn it over to you.
Great. So let me do a quick agenda review with you all, which you should see on the screen now. So we've just completed introductions. We're going to do a very brief GBRICS refresher for you all right now, but we aren't going to have time for question and answer. This is really just to get us all grounded. But we are planning 2 GBRICS orientation sessions, which were in your packet with those dates included. So if you are interested in learning more and asking more questions about GBRICS, you can tune into either one of those orientation sessions. GBRICS Council Structure and Approach will go over our draft work plan for the council, have a discussion on the vision and guiding principles for the GBRICS project. We will establish our Community Engagement Committee and then end with any announcements that we have. So I'm going to move us forward to the GBRICS, just giving you an overview of the GBRICS project. So as many of you are aware, this is a 5-year grant that was awarded to, or the GBRICS project was a $45 million grant awarded over 5 years to invest in behavioral health crisis response infrastructure and services in the greater Baltimore region. We are defining the greater Baltimore region for the purposes of this project as Baltimore City, Baltimore County, Carroll County, and Howard County. The proposal itself was developed in collaboration with 17 hospitals, 4 local behavioral health authorities, behavioral health experts, and community experts from across the region. Some of you who I know are a part of our council and know many of the other partners that contributed to the development of this. The funding comes through the HSCRC through enhanced rates to the hospital systems. And if you're interested in learning more detail about the project, we did create a GBRICS webpage that is listed at the bottom of the screen. The overall goal is to reduce unnecessary emergency department use and police interaction for people in behavioral health crisis. And we look to do this by really building upon the strengths of our current existing crisis services that are already in the community. We have, across all 4 of these jurisdictions, we have existing behavioral health crisis services, and GBRICS is looking to build upon that, strengthen it, and improve it by investing in those infrastructure and expanding services, with hopefully helping to better resolve crises for people in the community more quickly, and get them connected up to the ongoing care they need in the broader public behavioral health system. The proposal includes several key elements. First is investing in a care traffic control system. What this is investing in the tech infrastructure to support a regional call center that would have the ability to track people or track services track the deployment of people to address the crises in real time. It would allow us the ability to deploy mobile crisis teams with GPS tracking technology so we can see where they are out in the community, better coordinate the dispatch of mobile crisis teams across the region. It would also allow us to make referrals in real time. It will also give us more robust data than we currently have on behavioral health crisis services, and ultimately we would then use this data to inform building out some of the other services. The second is expanding mobile crisis team services. All 4 jurisdictions have mobile crisis teams, but to varying degrees in terms of if they're 24/7 or not, and varying staffing models and approaches. So what we're looking to do is expand mobile crisis teams, especially in communities where they aren't 24/7, to make them 24/7, and then have regional mobile crisis services to support the overall region. And then this would be also at the same time, we'll be developing standard practices that we could then apply across the entire region. The mobile crisis team service expansion part of this proposal would be phased in over the course of the 5-year project. The third component is walk-in or virtual crisis services, or what we also call same-day access services. This is working and looking to really build upon our existing outpatient infrastructure across the public behavioral health system. So what I mean by that is looking to partner with outpatient mental health clinics or opioid treatment programs. Those kind of fall into that category of outpatient clinics, to work with them to offer virtual or walk-in appointment services. So this would be looking to have a consultant partner and support providers to look at things like changing their clinical workflow, for example. And so we would also phase this in over the course of the 3 years. But the thinking behind this is that we have strengths in our current system that we need to build upon, and that would be our outpatient infrastructure, and seeing how we could use that infrastructure to better help people get immediate access to services when they're experiencing a crisis. The fourth component would be community engagement and outreach. And this is a long haul thing that we felt was so important. The HSCRC felt was important, that they wanted us to build this component into the proposal, but it's recognizing that we've got some culture change and system change that we need to support while we're also implementing these service enhancements. We know all too often we are over-reliant on calling 911 or using the emergency department for crises. So shifting that community shift is kind of a long haul that goes beyond, I think, the life of the GBRICS project, the 5 years of that. But we want to start to support that culture change with grassroots community engagement, but then also through paid community engagement and marketing. And some of that would be marketing the hotline, for example, as an alternative to calling 911. The fifth component would be that nonprofit multi-stakeholder accountability structure. And that's where the GBRICS Council comes in, and we'll talk more about that later throughout this meeting. But the accountability structure is an important piece, that we have the GBRICS Council, which is then supported through different committees that will help with overall implementation of the work, and then the regional administrative manager, which BHSB serves in that role to help with day-to-day project management. What you see on the screen is a kind of a screenshot of what that multi-stakeholder accountability structure looks like with the GBRICS Council. And we've got our standing committees, one of which that we will establish today, the Community Engagement Committee, and then the regional administrative manager, kind of responsible for that day-to-day implementation of the different components of the GBRICS project, which you see kind of represented some of the work groups that we have not yet established but plan to establish to help us think through implementation of the different components. So in terms of implementation, you've heard me say a number of times that we've got 5 years to implement this. Year 1 and year 2 are really heavy planning years and building years. We'll be doing things, especially in year 1, like thinking through how we structure a procurement for community engagement, how we structure procurements for identifying a consultant to help us with the same day access. We'll be beginning the work to identify what those regional standards should be and local protocols for mobile crisis teams. So a lot of convening and planning out will happen in year 1. Year 2 will be a little bit more of the same. We'll also be trying to develop procurements for the mobile crisis team vendor. We'll start implementation of certain elements like the community engagement work, for example. We will hopefully start the implementation of the care traffic control infrastructure in year 2. Year 3 will be continuing some of that work, so expanding mobile crisis team a bit more, mobile crisis team services across the region a bit more, continuing to expand that community engagement and marketing. And years 4 and 5, really hoping that we can start to measure that impact and focus on the sustainability, which sustainability is a key piece of this project that we'll be working on throughout the 5 years. But there's got to be, really starting to see some of that shift happening in year 4 and 5 in terms of sustainability, and that would be looking at things like supporting sustainable reimbursement structure for certain crisis services, as an example. And some of that sustainability will be, a lot of that sustainability we anticipate will be work that will be supported by the GBRICS Council. So that's what I've got for in terms of refresher. I think I kept within my time frame, so that's good. At this point, I would like to turn it over to Diane.
Just going to the unmute. Hello, everybody. Good afternoon. And we could go ahead and go to the next slide. So moving to the next section of the agenda, which was sent out to all the council members, there was in your agenda packet a couple of different things that I wanted to call to your attention, which if you haven't had a chance to take a look at it, may be helpful for you to refer to as we have the discussion. First of all, there was a memo to the council members from Adrian Bridenstine. And if you look at page 2, it parallels this section of the agenda, which is around the council structure and approach. So there's 2 things that we need to do. One is a high-level review of what is in the draft bylaws that was sent out, again, with the agenda. So all of the council members, it was referenced in the memo, but then a separate document is the draft bylaws. It's just a 4-page document. So hopefully, if you haven't taken a look at it, it's easy enough to open it up and review it. So we'll go through that. And then the second piece for this section is to do a council vote for the leadership of the council. But before we get to that, the content of the bylaws, as you can see from the slide here, is basically establishing a 21-member council, and that was actually part of the proposal that was approved by HSCRC, very deliberately designed so that there are specific seats for specific stakeholder perspectives. The council is to, and given the 5-year term of this grant, thinking about the 5 years at this point, the council members would hopefully serve for the 5 years, but there's clearly aspects of the bylaws that deal with if there are resignations, if a council member needs to be removed, if the vacancies need to be filled. And again, there's no surprising content. I can certainly share the detail if you want, but if you take a look at the bylaws, it's all set forth there pretty clearly. The council will meet at least quarterly and the meetings are open. A majority of the council present is considered a quorum, and the council will meet virtually, but could also meet at some point in person. We're hoping within the 5 years that'll be possible again, but right now for the time being, of course, it'll be virtual. Each council member has 1 vote. However, because there are representatives on the council that represent hospital systems that have many hospitals in many parts of, in more than one part of the region, which again includes the 3 counties plus Baltimore City, the hospital systems are allowed to have an additional person attend the meetings and be part of the council meetings, but they'd still only have 1 vote. So there is a recognition in the bylaws for those non-voting hospital system representatives. The bylaws also establish leadership of the council, which essentially is 2 positions at this point, chair and vice chair of the council. Certainly the council, if the council determines that there needs to be other leadership positions, the council can add that in the future. But we're starting with with chair and vice chair. And then Behavioral Health System Baltimore, as the regional administrative manager, would function as the secretary. So the chair and the vice chair would be elected by the council, which again is part of what we're going to do today. The terms of those leadership positions are for 2 years. It's important, given the priority on diversity, that the two positions, the two leadership positions, cannot be held by the same stakeholder type. In other words, both positions cannot be held by hospitals or held by local behavioral health authorities or whatnot. There needs to be diversity and perspective for those two positions. The chair and the vice chair can be reelected after the 2-year term if the council chooses, or other people can be elected into those positions. That would happen every 2 years. And I mentioned the role of the regional administrative manager as secretary. And then as Adrian referenced earlier, the council is charged with creating standing committees. There are 2 standing committees, again, that was set forth in the proposal approved by HSCRC, which is a policy and advocacy committee and a community engagement committee. Those are 2 committees that are required by the proposal and also would be required by the bylaws, hopefully once they're approved by the council. The council can establish other standing committees if the council decides that that's necessary. On the committees themselves, the council members can serve on those committees, but part of the intent for the committee is that others from the community would serve on these committees. So that is and then for each committee, the committee would elect a chairperson for those committees. That's a really high level review of the bylaws. There's some obvious things in the bylaws, of course, by a vote of the council, the bylaws can be changed. So that is a high level review. What I would appreciate is if any council members have any questions or comments about the bylaws before we bring the council to a vote whether to adopt the bylaws. But first, I'd like to open it up for any questions or discussion from council members. I'll also say, if you're having any issues with your audio, we also have chat open, so you're certainly welcome to make your comments in chat. I see, for example, Ben Launer has said he has no questions regarding the bylaws. So thank you, Ben, for weighing in on that.
Hey, Diane, it's Maria. Real quick question. Is this subject to open meetings? And while I understand the hospital partners can have an extra person, can folks just observe?
Yes, the meetings are open meetings. So just like today, where there was information that was sent out to anyone who's expressed interest in GBRICS about this meeting, they can attend. So we've got, the last I looked, let's see, 21 people who are attending just to observe this meeting, and
Great.
that will continue to be the case.
Thank you.
So the meeting announcements, that's the other piece of the bylaws I would mention, is that there is a requirement that the meeting time and place and information needs to be announced in advance. And the regional administrative manager has committed to not only sending that out, but I believe the information will be posted on the GBRICS website. Yeah, I see Adrian nodding. The intent as well is to post these bylaws on the website, the council members and the bylaws, after this meeting today, hopefully with the decisions that we're anticipating, that information would also be available on the website. So we want to make the GBRICS process as transparent as possible for the entire community. Any other comments or questions on the bylaws? So one of the other pieces of the bylaws, I should say, is that it does say that the meetings would be operated basically following Robert's Rules of Order. So with that, is anybody interested in entertaining a motion to approve the bylaws?
Brian, oh, go ahead, Brian, you got it.
Thanks, Chuck. I'll make a motion to adopt the GBRICS Council bylaws as circulated before the meeting and it's just presented.
And I'll second them for you then, Ryan.
Thanks, Chuck.
Thank you, Ryan. Thank you, Chuck. All right. With that, all council members who would vote to approve the bylaws, please say aye or type it in the chat.
Aye.
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 Aye. Aye.
Any nay votes? Okay, not hearing or seeing any. The bylaws have been adopted. Thank you very much for that. So now that you've adopted the bylaws, the next order of business is to elect the leadership of the council. Adrian sent an email to all council members a few weeks ago asking, basically letting everybody know that this opportunity was available to throw your name in the hat or throw somebody else's name in the hat. We did also want to allow for people to encourage their peers to be a candidate for chair or vice chair. The two people who came forward, not only whose names were suggested, but also individually came forward and expressed interest in these positions. You see their faces and names and positions on your slides. A candidate for chair is Nikki McCann, who is the Vice President of Provider and Payer Transformation for Johns Hopkins Health System. And then the candidate for vice chair would be Andrea Brown, who is the Executive Director of the Black Mental Health Alliance. I will say, I personally think GBRICS is incredibly lucky to have these two women stepping forward and being willing to serve in these leadership roles should the council vote to approve. And what I'd like to do, I could certainly give a little more information about the background. Again, council members, you received a memo from Adrian Bridenstine. If you take a look at page 2, there's the bio of both Nikki and Andrea. And so that would be a good place for you to reference for more information. But I'd also like to give the opportunity for Nikki and Andrea to say a few words about their background, but also their interest in the leadership role on the council. So if you wouldn't mind, Adrian, go ahead and go to the next slide. And Nikki, if you wouldn't mind unmuting and say a few words about your background and also your connection with GBRICS, and then we'll turn it over to Andrea afterward.
Great, thanks, Diane. So Nikki McCann, I'm with Johns Hopkins Health System, and I've been with Johns Hopkins a little over 11 years now, serving many roles at Johns Hopkins, previously in government affairs, and then with Chief of Staff for the Johns Hopkins Hospital, and now in my new role. Prior to working at Johns Hopkins, I worked for the Maryland General Assembly. I staffed the Appropriations Committee, and I was committee counsel to the Health Subcommittee. And I'd say that's the first time in my career where I think I found my passion. Was working in healthcare policy. And back then, that was about 15 years ago, access to mental health services and substance use services was a real challenge back then. It was an issue that has followed me to my career at Hopkins, with continued frustration about the lack of access to services for people who need them. And I am thrilled to be part of GBRICS because I feel like this is the first time in a long time we're really putting a meaningful solution on the table, a robust and comprehensive solution to a problem. This is something that's been sort of nibbled around the edges with programs here and there, but this is a really robust solution that we have all come together to put forward. It's been an honor to work with the team of people who've made this happen. This is a collective effort, and it's just really been great to be part of it. And I will tell you that personally, I have always been invested in this issue. I don't share the story often, but my father struggled with substance use his entire adult life with drugs and alcohol. And it is something, that eventually, had him die at a very young age. And he had a loving family, and he had all the supports that life could have to offer. And I think about his struggle and how hard it was for him. And then I think about all the people in life who don't have access to supportive families, to outside resources to help them with their struggle. And so that's one of the reasons why this has been personally a real passion for me.
Thank you, Nikki. Andrea.
So hi, I'm Andrea Brown. As you know, I have been with the Black Mental Health Alliance. I have to always tell people I came 2 weeks before COVID, didn't know the staff, and now we're working at home. I'm like, you work where and you work where? So again, I've been now 11 months with the Black Mental Health Alliance serving as the executive director. But prior to that, I held 18 years at the National Association for the Advancement of Colored People. I had oversight as a vice president for strategic planning and partnership, among other things. And so just so if you want to do the math, I had 18 years there, started when I was 20, so I'm really 38. Okay, that's not true. But the truth of the matter is, this is what I know. This is super excited. I was super excited when I learned about it, because I think it does a couple of things. It gives voice to brown and marginalized communities, and to Black and brown communities, but also it really helps us understand what access looks like and what some of the needs are that we don't often talk about. And it's interesting, as Nikki shared about her father, years ago, I had an aunt who committed suicide, and what made that, and apparently she had been depressed for years, but because historically Black and brown people, there's a stigma around mental health and accessing services. And so that has been such a driver for me, so that number one, folk have voice, and number two, we understand what that really means. And so again, I am excited to be here. And I think that's where I am today.
Thank you. Thank you for both of you, again, for providing some background, but most importantly, being willing to step into these leadership roles. I'd like to open it up if any council members have any questions or comments before we take this to a council vote.
Go ahead, Ryan.
I was just going to comment and personally, and I know that we're all coming at this from different evolutions of this project, but BHSB has done an extraordinary job as the regional administrative manager, I guess is the formal title that we'll call you now in order to get us here. But the person who really led this effort from a particular groundswell perspective has really been Nikki on behalf of all the hospitals, as well as the multi-stakeholders that have been involved. And so from my perspective, she's already been informal in terms of guiding and leading this particular approach, particularly with her policy expertise, which has been extraordinarily helpful for this group. And just I'm so happy that Nikki's taking on this role of chair on behalf of the hospitals. And then Andrea, it's nice to see you from a different environment and know that your skills and expertise also. I think we have two terrific candidates that we should be very proud of as a council to start this work together.
The words out of my mouth, Ryan. I couldn't have said it any better. And, Nikki, I've known Nikki for a long time, and she really has taken the lead on this. And, Andrew, very nice to meet you. And I think you will bring such a unique perspective that we all really need to hear. And so happy to have you as part of this.
Thank you. Again, if anybody else wants to make a comment or have a question, you can certainly do that verbally or use the chat. So what I'd like to do is first, we'll do this one by one. If anybody is interested in making a motion to elect Nikki McCann as chair of the GBRICS Council.
So moved.
Second.
All in favor?
Aye.
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 Anyone against? Abstentions? All right. Nikki, you are now council chair. Congratulations.
Thank you.
Calling the question regarding Andrea Brown for vice chair. Anybody willing to entertain the motion?
I'll make the motion.
Motion for approval.
Second?
I'll motion to second.
All in favor?
Aye.
Aye.
Anyone opposed? No abstentions? All right. Congratulations, Andrea Brown, for being vice chair of the GBRICS Council. We now have our leadership, and may we be worthy of your leadership. We know that we are all very lucky to have both of you in these positions. So with that, I'll turn it over back to Adrienne.
All right, thank you, Diane. Congratulations, Nikki and Andrea. So next thing on the agenda is to talk through the council draft work plan. So one of the things that we have been doing in the interim as we've been working to get the GBRICS Council established is starting to look at the different components of the GBRICS project and map out a work plan for them, which has ultimately led to a draft work plan for the council, which you see on your screen. You also got a draft work plan included in the packet that I sent out yesterday. So if you have that, what we'll show you on the screen is the same thing that you got in your packet yesterday, but just wanted to note that you also have a copy if that's easier to look at. So like I was saying, we've started to map out a work plan and wanted to give you a preview of what you as the council could come to expect for this first year of GBRICS project implementation. So what you'll see in the work plan is just an outline of the meetings for 2021. We do anticipate that the council will need to meet 6 times this year. That's where we are currently with anticipating what the workload will be. That obviously could change to be more or could be fewer meetings. So I say this to say this is a work plan that it will always be a changing and work in progress type of thing as we gather more information on the different components and how we plan to implement them. What we've tried to map out for you to see is where certain key decisions that will need to be made over the course of the year are, where we will anticipate needing the council's strategic advice, and certain times that we'll be sharing certain pieces of information on how we're doing with implementation of the overall GBRICS project. So you see that outlined in the first slide that I've got up there on the screen for you. February 16th, our meeting today, you see we've made a couple of decisions. And where we're looking to get advice today from you to the extent you can is input on this work plan. We'll also be talking a little bit about the guiding principles. And so we've kind of used that structure throughout. We do anticipate that we'll need to meet in March with the purpose of that discussion, or the purpose of that meeting being to continue to forge ahead with the community engagement and marketing information. That's a really important component, early implementation component of the GBRICS project, and also with the care traffic control and mobile crisis team work groups. And again, all of this is trying to, all this work plan information is intended to align with what we put in the proposal. That's also just a thing I wanted to note. We'll anticipate also meeting in May, again, with getting some input on community engagement as we move forward with that. But we also will plan to establish the policy and advocacy committee then, which is the other, as of this point in time, the other standing committee for the GBRICS Council. The timing for that is just because we wanted to get through the legislative session. We thought that would make the most sense at this point. Let that kind of the dust settle from the legislative session and then establish our policy committee after then, with the goal of trying to move forward with figuring out what the GBRICS policy agenda will be going forward. Meeting in July, we'll have our first semi-annual budget review of the GBRICS financials. We'll have an overview of our approach to the same-day access or virtual access pilot. So hopefully by then we'll have a clearer work plan. We'd be sharing with you about that at that point in time. We'll have some preliminary thoughts on how our stakeholder engagement for developing the policy agenda. and we'll start the discussion on value propositions and ROI statements and how we would engage other stakeholder groups. And then as always, there'll be updates from different committees and work groups. In September, we anticipate approving the GBRICS policy priorities. Timing is to give us time so that we know, looking ahead, what we'll be working on potentially in the next legislative session, and that gives us what we're hoping to be enough leeway to start doing some of the groundwork in terms of advocacy and outreach we might need to do to advance any certain policy initiatives. This is a really important part. The policy priorities, I think, will be a really important guiding document for the council. As we mentioned earlier, sustainability of the GBRICS project is going to be what we anticipate heavily focused on policy reform that would happen at the state level, local levels, and even potentially the federal level. So the policy priorities and having your buy-in and thoughts on the policy priorities and getting those done earlier rather than later will help us with our strategic approach to trying to advance the sustainability piece of the project. And then hopefully by September, we'll have some preliminary drafts on mobile crisis team standards and preliminary thinking on the care traffic control infrastructure implementation. And then finally, December is what we're anticipating to the last meeting of the year. We'll present to you, the regional administrative manager will present to you a work plan for year 2. That work plan would be based upon a lot of stuff that happens in year 1, and we'd want to get your input on that. We'll have input on care traffic control and operations plan, which will be something that we'll be working on over the course of the year. Input on an advocacy strategy for 2022, which would be based upon our policy priorities that you approved at the previous meeting, and then of course, updates. So that's as of now, as of February 16th, that is the outlook for the council work for 2021. Let me just pause and see if there are any questions. Oops. I'm trying to find the chat if there are questions coming in the chat too. We did have it open at one point. Any feedback for us?
I just, this is Chuck. This is the work plan for the council, obviously. For some who don't know the GBRICS project, the only reference we have to the project work plan is the broad overview slide that showed the phases. Does it make sense for us to be able to link this for some people who may not be as familiar with the, on the ground project work plan?
Yeah, that's a great point, Chuck. And that's part of why we thought we would have the orientation sessions for the council that we've scheduled to allow you guys to ask more questions for that. So I will say, to Chuck's point, we have different work plans for the different components of the GBRICS project. So care traffic control, mobile crisis team, and trying to map, as an example, trying to map out the timing for implementation of those different components. We've looked at those and tried to then have taken that information and folded that into what is the council work plan, and knowing where we need to get your input on on the implementation of the different components and where we might need your strategic advice. We could and we plan to at a future meeting share more detail on those work plans. I will say some of them, and they're always going to be kind of a moving target. Some of them are not fully fleshed out yet because we just don't have enough information, but that is why I say this, that's why I say these are moving targets. And as at this point on February 16th, this is what the council work plan is, but it could change going forward as we continue to map out those different components. I don't know if that fully answers your question. Okay.
Adrienne, if I could add, one of the things that is a key component in playing through the development of the draft work plan overall is sequencing. Understanding that decisions in one area will affect decisions in the other. For example, when you talk about the care traffic control and the mobile crisis teams, they clearly connect to each other. And I mean, literally and figuratively. So the standards and protocols for one affect the other, just like the community engagement and outreach can affect the other pieces. So So it's a big part of this first work with the draft work plan is just figuring out what needs to follow what needs to happen first, and then playing it out in more detail. But Adrian, maybe for the next meeting, that's a strategic advice item or an information item we could add for the March meeting.
Are there other questions or comments?
Thanks for all your work on this.
Adrian, I have just a quick logistics question. I know there was a poll sent out for folks to decide when the meeting dates are. Is that still in process or has that been determined?
We have not gotten feedback from everybody on the poll, but we do, there does seem to be a date that is emerging to be the one that works best for everyone. And it's looking right now like it will be the second Mondays of the month. But I pinged a bunch of people this morning and need to give them a chance to fill it out. So you probably hear from me tomorrow about when it will officially be standing meeting time. Any other questions or thoughts on the draft work plan? I'm not seeing anything in the chat. If anybody wants to say anything, you are on mute. All right, I'm not hearing anything. I will say this will probably not be the last time you see the work plan because as we've noted a couple times, it is a moving target and we anticipate that it will change as we move forward with implementation. So thank you. And I'm going to turn it over to Nikki.
Great, thanks, Adrian. Next on the agenda, we wanted to talk about the vision and the guiding principles. We had the group that had been convened, also with stakeholder involvement in drafting the vision and guiding principles were really used to help frame what got submitted in the RFP. So the guiding principles were established and the vision, and those helped influence what we ultimately put in the RFP. But now that now that we are approved and the program is launching, it probably makes sense for us collectively as a group to revisit the vision and the guiding principles and make sure that what was established prior to submission still makes sense to this group and should be our vision and guiding principles moving forward. So as you can see, the vision is to establish behavioral health crisis care as a fundamental element of emergency response and of suicide prevention in the Baltimore region. And I won't read them aloud, but I think you can all see the guiding principles outlined here. So really we wanted to take this time to open it up for discussion on your thoughts on whether or not this is the right vision that should still be guiding us, or these the right guiding principles. Now, something like include elements of the Crisis Now model, that is a component of the RFP. There's no negotiating on that. But let's just take a few minutes to discuss, our thoughts around whether or not we still have the right vision and the guiding principles. And please feel free to either speak up or put your comments in the chat.
Hey, this is Ben Lohner. I just wanted to say I'm glad that we're finally incorporating some of the behavioral health considerations into emergency response. 911 is typically the catch-all as our emergency departments for things like this, and we could certainly do a better job, and behavioral health resources are always strained. It's not even a matter of not wanting to do it. I often find that the resources sometimes are either difficult to connect people with, or it's just not a part of kind of emergency response. So this is a good time, at least for the fire department, because we've got the police department engaged and the fire department engaged in a complete overhaul of dispatch protocols. So I think this discussion is very complementary, to the need to address some of these things in a much better and more effective way. So happy to be involved.
Thanks, Ben. Any other thoughts on the vision?
I had one comment. I wondered if we wanted to have an equity statement front and center in our vision, you know, across race, culture, age. I mean, all of the different issues that I think are important to raise. I mentioned the age issue because, you know, there certainly have been some age groups whose needs have been less attended to where crisis services are concerned. And then we have access issues across a variety of sectors of the population. So I think that would be important to add to the vision statement.
I think that's great feedback. Do others agree?
Yes. I think it's imperative.
Definitely, I think it's imperative.
Yes. Hi, Adrian, this is Stephanie. I know we've talked several times about the minimized police involvement with response to people amidst a behavioral crisis response, and somehow just feel like we need to, once again, I'm trying to think of the right word. Since Baltimore County continues to have a police clinician model, I don't know if there's any way to change that to represent a non-police clinical model, if that makes sense.
Just, Stephanie, just to make sure, I think we're understanding you correctly, that you're saying that in Baltimore County, your approach is that you have a successful model where there is police involvement.
Yes.
Right, and you want to make sure that that's recognized going forward.
Yes, because that is the model, and it's one that's been in place for a while. And I think perhaps a distinction could be made between a police response, like general police response, versus a police response that is combined with a behavioral health program. If that explains it better, because I see it as two different approaches. When I think police involvement, I think like potentially, for lack of a better word, I don't know all the police language, but say a patrol officer or someone responding, you know, from that, as opposed to a program that has the combined model. So I know this has been a topic of conversation several times, but when I'm seeing this in this vision, I don't know if there's a way to better define it.
Just to throw in, I think the idea of minimizing police involvement whenever possible allows for quite a spectrum, where there's many crisis situations where law enforcement really does not need to be involved at all, and others where perhaps law enforcement does need to be involved. And if that's the case, then with a clinician absolutely is a better situation than without a clinician. So I like the idea of embracing a wide variety of options, but really focusing on how do we build our capacity so that law enforcement does not need to be involved with crisis situations they don't need to be involved with. That's to everyone's benefit. The other thing, while I'm speaking, is just, and I don't know whether it fits in here, but when we're talking about crisis, you know, the crisis is the moment, and then there's what happens before and what happens after. So hopefully part of what happens with GBRICS and the increased coordination is awareness of all of the community supports that are available to help people after they've gotten through this initial crisis, then what? So that there's a really warm handoff into community-based recovery supports. Whether it belongs in these guiding principles or just in general is a question to be resolved, but I wanted to bring that up.
I just wanted to speak very briefly about this police involvement, because certainly I worked, you know, before I did medical direction, I also worked in the field. Baltimore is certainly a very challenging place, as I know that everybody can appreciate to work. There's certainly a lot of violence and a lot of hazards, not only to providers. As a matter of fact, I have 2 providers that are out on a line of duty injury from a behavioral health call that unfortunately escalated where police were not involved. So I just want to say to the council, this is something that we feel very strongly about. We're working with BCRI to revise dispatch protocols. I think this is certainly a best practice model, but remember when we're dealing with, it's not like there's always a clinician that is answering the dispatch phone. So sometimes it's always difficult. It's not due to a lack of intent or a lack of willingness to send the right resource. It's that, number one, some people call 911 with multiple complaints, and that's very hard to kind of sort out when you're dealing with a sort of a pre-recorded triage mechanism, if that makes sense. So I'm really glad that we are moving forward, but sometimes it's more difficult when we say we always want to minimize police. Sometimes the request on behalf of the patient who's calling is not always clear. And if you're dealing with a call center that takes thousands of calls per day, sometimes it's not it's not just inertia. It's really trying to get the right resource to the patient. But I think there's lots of progress, and I'm hoping that the city will serve as kind of a template for a 911 model where we can send a behavioral health clinician as opposed to police.
So Dr. Hepburn, I don't mean to put you on the spot, but I know you have a national perspective and expertise. I was wondering if you could share any guidance from your perspective on some of the best evidence-based models nationally. Is Dr. Hepburn still here?
Hey, Nikki, it's Krista. He had to jump off the call for a minute, but he should be back on very soon. I think it would be a great question to hold until he gets back on.
The other comment I wanted to make on the guiding principles, and not to be a get into the wordsmithing of all this, but since we're reacting to words on paper, the line about substantively involving community partners, I think that the work thus far from GBRICS and then the work that we want to be intentional about just does more than involve community and partners, but it's done in tandem. And so kind of removing that power structure of, a line that looks as communities on the peripheral, but communities integral to the operations and the guidance and leading it, I think is really important to change and correct whatever words we want to use. I don't use the best words after 4 o'clock in the afternoon, but comment there.
So, Ryan, what would you think of substantively collaborate with community partners?
Yeah, and I think community partners and communities, because sometimes, we'll ensure that we want the voice of the actual communities in addition to the service organizations in those communities.
That makes sense. Other thoughts? Any other thoughts to share on either the vision or the guiding principles? I just want to make sure that I'm, as this discussion moves forward, that we're capturing sort of the additions in the right places. So I think there was consensus that within the vision, we would make sure that in the center of the vision is reference to health equity. The guiding principles, what we've heard so far, is sort of, looking at that language around police involvement, and we'll be looking to Dr. Hepburn for some guidance on that. Recognize that this is not just, substantially involve the community partners, but they are a true partner in this. And then also, I think it was Katie who you raised the point about making sure that there's increased awareness about available community service. Have I missed any of the major comments? Any other thoughts around the vision or the guiding principles? Diane, Adrian, Krista, do we want to wait for Dr. Hepburn to come back and revisit this, or bring this up at the next meeting?
I just texted him to see if we had a time estimate, so I can't give you a time estimate, but he said his meeting ended at 4, so.
Okay. As we all know, Zooms tend to run over and over and over.
I mean, I will say this probably won't be the last time the council will see these guiding principles. We did have them, if you remember the work plan, we did have them as something that we would need your input on next month, because the plan is that we'll take these suggestions and revise them, and maybe next month potentially have some wordsmithing. I will say, I think, I don't know if we're settled on the minimized police involvement with response. I would really like to hear Dr. Hepburn's response on that and what he might suggest. So I guess I'm not quite sure how to edit that exactly. And without him, without an opportunity to hear what he has to say, I'm not quite sure what changes to make to that one just yet.
And Adrian, this is Krista. If he gets back on, I guess we can always ask Dr. Hepburn. Maybe he can work with us outside of here to craft some language. We also have some language in the city for the consent decree vision for behavioral health that makes a distinction between the specialty response and the general CIT response. So we have some language we can pull from and see what Dr. Hepburn thinks of it.
If I could weigh in as well, this is Diane. There's also language we could look to from the SAMHSA national standards for behavioral health crisis response. And frankly, I think this language is close to what was in those national best practices, which is what we drew from. It may not be this exact wording, but we can look at the wording around that as well.
So why don't we do this? Why don't we, we'll wordsmith the areas where we all felt comfortable with the changes, and then potentially have this as an agenda item at the next meeting. Does that make sense? Okay. Any final comments on the vision or guiding principles? Thanks, everyone.
Thank you, Nikki. Your first official act as chair, and I am noticing I'm not doing the best at advancing these slides either. Sorry about that. Now we're, Diane, go ahead.
Okay, all right, let's see. Okay, so again, members of the council, you received with your agenda the memo from Adrian Bridenstine. If you look at page 4 of that memo, it includes the information that's also on the slide. Based on the bylaws for the council that you approved earlier, one of the standing committees that is required as part of the proposal is a community engagement committee. So what the request before you today is to look at this committee purpose, discuss it, make any changes that you feel are necessary, and then hopefully you all will vote to establish this committee with this purpose, and then that gives the regional administrative manager the ability to then begin to identify members of the committee. The other piece in your discussion today is if you have specific suggestions for who you think would be really good to invite to this committee, that would be helpful as well. But essentially this community engagement committee has a few different purposes. Overall, it's around identifying the strategy and actions to engage communities. And as Ryan pointed out, there are community partners, but then there are communities. I mean, there are different ways to think about that meaningful involvement, collaboration, and partnership. So that's what this committee would be helping to advise the council and the GBRICS project overall about how best to do that. That advice coming from the committee would really formulate around 3 important areas. It would be recommendations to the council around how do we build community awareness of and engagement in the GBRICS. And as I mentioned earlier, it's the GBRICS development, implementation, and it's meaningful. It's that meaningful collaboration and partnership that we were talking about earlier. And that is in being aware that the GBRICS work is happening and then helping to shape it. We really want to make sure that this is reflective of what the community and community partners are interested in and need and want and their perspectives. So that's the first one. That is around GBRICS implementation. The second is around awareness of the behavioral health crisis response services and resources that are currently available. And as the various GBRICS elements come into play, whether it's the care traffic control and the hotline, the mobile crisis teams, the opening up of more same-day access to services, either walk-in or virtual. As those things are implemented, how do we raise awareness so people know what, what's important to know, so that they are move along the spectrum of being aware, being engaged, and being willing to use. And then that brings us to the third area, which Adrian mentioned earlier, which is a big, big piece, and that is the culture change. It's really helping this work and the council to make decisions and provide guidance around how do we motivate behavior change for all types of stakeholders. I mean, we tend to go right to individuals and families, and that's certainly an important stakeholder group or groups. But there are decisions and activities that community organizations make, providers, health plans, employers, community colleges, other educational facilities, so on and so forth, that can drive people to call 911, can drive people to show up in an emergency department, can drive a level of awareness or lack thereof about the GBRICS, the integrated regional crisis system. So how do we motivate behavior change among each of these different types of stakeholders so that overall we're shifting the culture to a different type of awareness and use of the behavioral health crisis system? So it's not a small purpose of this committee, but it's a fascinating set of areas and activities that the Community Engagement Committee would be called together to help shape. So that's a very high level description. And again, if you look at page 4 of your memo, that exact purpose is stated there. So go ahead, Adrian, if you go to the next slide, which is very simple. Just wanting to find out again, if anybody on the council has any comments or questions. We can move it back to the previous slide if you want to look at the wording of this purpose statement. But any questions or discussions before we then ask the council to actually formally establish the Community Engagement Committee?
Hey, Diane, it's Maria. Just one observation. I didn't see a reference to the faith-based community. And maybe that is lumped in with the community partners, but I think that'll be an important group of stakeholders that should absolutely be at the table to kind of socialize the goals and the work plan around GBRICS.
It's a very good point. There are any number of stakeholders, but yes, I think calling it out makes it very clear that it's the faith-based community is recognized as a very important partner in this process. Thank you.
Diane, I just want to make a general comment that there's so many things we've done in our field over the years that would be tremendously helpful to people, and they don't know about them. And so I think it is really important to not underestimate the challenges here in terms of raising awareness. And it would be helpful, I think, as we're getting started, to really think about whether there are significant gaps in knowledge base or specific sectors that we are very important for us to reach, and also whether we look beyond traditional means for how we get the word out and bring in expertise that might help us to do it better, because we don't typically do it well.
As Adrian knows, I will often comment that when people come forward and say, suggest the things that have always happened, and yet if we're finding that there isn't a level of awareness now, to keep doing the same thing is not necessarily the most effective approach. So yeah, Linda, very, very good point on look beyond traditional methods. And there may be more than one group that the regional administrative manager ends up contracting with to help with this, because of unique expertise and unique approaches. We're not assuming, and the proposal that was approved does not assume that there would only be one partner to help with this. We may end up tapping into any number that have unique expertise that could really create a multimodal, very effective approach.
Diane, there's a comment from Chuck too in the chat box. I can go ahead and read it if you want me to.
Yeah, Chuck said, it's significant that this is the first committee that will form. Strongly support having engagement with the community as our first operational council action. We heard that early on when we did a full day forum, when we were shaping the GBRICS proposal. And one of the recommendations that came out of that forum was A, community engagement is vitally important, and B, you need to start it as soon as possible. So very, very much aligned with Chuck's comment, and then Ryan said agreed. So it's helpful to see that support. Other comments or questions about the charge, the general purpose for this community engagement committee that would be formed?
Can you speak a little bit about the responsibilities of the committee members and whether the committee is envisioned to bring in other folks who are not on the council, or whether the committee is advising the partnership manager to contact? Can you just kind of speak a little bit more about the committee's responsibility, especially in the first, let's say, 6 months?
The main purpose of the committee is to make recommendations to the council. It is a committee that advises the council. That said, the assumption is that there, as it says in the bylaws, council members can be part of the committee, but the assumption has also been that this committee would be broader than, it's not necessarily a subcommittee of the council. It is a community engagement committee that members of the council who are interested can participate on. But frankly, one of the things we'd like to have from you all is if you have ideas or suggestions about who you think should be members of this committee. What comes out of the committee may in part be shaped by what the committee recommends. I realize that's sort of a circular answer to your question, but other than this high level purpose, we really also wanted to leave it to the committee to come forward, like Linda's comment about how there are that this is a really complex issue, that there are gaps and there are challenges, that the committee might come back to the council and to say, we recommend, a subgroup, or we recommend, these 3 or 4 things that need to happen that may not be recognized in the purpose. We did not want to presuppose too much, frankly, until the group comes together to really suss out what's needed to meet these purpose statements.
And this is Adrian. We would like to get this committee convened sooner rather than later, because if you recall from the draft council work plan, the community engagement piece is one of the early implementation pieces that we have frankly already started thinking about, and really need to get this committee's advice and input on how we move forward. So the suggestion on members, I think, would be welcome in this discussion today. And also if there are certain council members who are interested in serving on this committee, we would love to hear from that. This would be a committee we'd like to convene potentially next month. Not potentially, we will convene next month.
And it may grow over time, frankly, as the group comes together. They may say, hey, we really need this perspective X represented and we don't have it yet. We need to bring in these other folks. So I suspect it would be an evolutionary process. Do people have suggestions? I'm keying off of Maria's comment about the faith-based community. Clearly that's a stakeholder group that we need to make sure is represented on this committee. Are there other stakeholder types that you want to see in this committee, particular groups that you think of that you say, oh, we really need to have somebody from on our own? Not to put you on the spot, Katie, but that's just who can.
I mean, I'm in like Flynn, like obviously. But so other groups, folks who don't speak English as a first language, I think especially as we look at different communities that may be dealing with the digital divide, and also just culturally responsive services. If you don't have culturally responsive services, they're like literally not available in your language or in your neighborhood, obviously you're not aware. So specific groups there within, I don't know. I'm sure folks working in different jurisdictions have insight on that, but I think that's a huge piece of this, especially if we're looking to reach people who, right, looking at awareness.
So one of the areas that comes to mind for me when we were putting together the proposal and talking to different groups about who was interested in basically signing on to say, yes, we want to participate, we want to be part of this, you know, the LGBTQ community, community colleges. I was delightfully surprised in talking with some community colleges, not only about how interested they were in supporting the proposal, but also how much they are directly affected by dealing with behavioral health needs and issues within their student population. So there may be, again, sectors or slices within the population where we want to make sure that those, it's a unique perspective that they bring to the table when we think about how do we engage those different communities.
Diane, if I might ask a question of the council, you know, one thing we need to consider when we think about community engagement is the differences across the geographies in terms of, you know, the city and the different counties that, you know, they look different, and the partners that we may need to engage look different. So not to, you know, put our geographic or our county representatives on the spot, but I would be very interested in hearing from you all who you might suggest be part of the community engagement committee, because I feel it's important to have that geographic representation as well, because Baltimore County and Carroll County look different, and how can we make sure that we are informing our strategy with those, you know, geographic nuances. So I'm sorry, Sue, Carl, and Stephanie, but I'm kind of putting you on the spot.
Hi, this is Stephanie. I'm happy to think about it. I don't have an answer for you right this minute, but I agree there's probably some groups that will differ a little bit from the other jurisdictions.
Adrian, this is Carl from Howard County. So are you, I may ask you to repeat the question because I want to make sure I answer it. You know, I'm thinking of groups that are unique to Howard County or groups where we already have existing relationships, because I think that is going to be another challenge for us. It's not just so much that the groups are unique, it's that we might have different relationships with different groups who are going to fit into this model in different ways. And so yes, we want to navigate that properly and transparently for them.
Mm-hmm. So I think it could potentially be both, right? Groups that are definitely groups that are unique to to Howard County, because my assumption is that you know, groups that are Howard County specific are going to know the landscape in terms of the service landscape, the political landscape, the community landscape, and how we might engage within that landscape in Howard County. So those kinds of you know, expert and key informants, I think would be really important partners to have, you know, informing the community engagement strategy. So, you know, I know Howard County a little, and the one group that comes to mind for me is the NAMI Howard County. They might potentially be a partner that should be part of the community engagement committee. But I'll just say, you know, we're city focused, so most of my connections are with the city. So I would be relying more on, you know, some of you guys, your other partnerships to help, or your partnerships to help fill out the committee.
Well, I mean, I think, you know, we have the Horizon Foundation, which I know helped us tremendously with this proposal, and they've been doing a lot of community engagement work. Okay. You know, I think, you know, and I could probably even brainstorm a little bit with Howard County General Hospital and think of some groups that we have. You know, we do some, you know, programs where, you know, it may be good to have, you know, some service providers, right, sit on the community engagement side in addition to, you know, kind of advocates and thought leaders. So I think I could definitely give this some thought and come up with some good recommendations for you that really try to kind of capture various populations and various interest areas. I mean, I think we have ACS, we have an Association of Community Services here since we're so nonprofit driven. I mean, I think ACS would be a good organization. They represent a lot of service providers like our domestic abuse service providers, providers where mental health will intersect. Oh gosh, I mean, we have a local LHIC that I know has our Local Health Improvement Coalition, I know has a mental health subcommittee. I know every jurisdiction has an LHIC. Our LHIC has a particular focus on mental health. They'd want some opportunity to weigh in here. We have just formed a new kind of local behavioral health advisory board. I mean, again, this is part of the state charter to have a core service agency and a local addictions authority merge. So that's the product of our merger of substance use and mental health services on the county government side. So they might want to weigh in. Okay. And then, you know, if we want to think about service providers like Grassroots, Shepherd Pratt, you know, Way Station, which is Shepherd Pratt kind of on a local level. I mean, we could bring them in too, but that's where it gets into the area of, you know, who are already providing services and how does this impact their service delivery model? So I think that's the question that comes to my mind on that aspect. Mm-hmm. But that's just me kind of thinking off the top of my head in terms of places where we can start.
Good suggestions. And I would welcome if you wanted to go back to your Howard County counterparts to think through who you might suggest for this committee. That would be great.
Yeah, and and I apologize, I might have missed this. Is there like a description about the committee, or like, is there like a charge done for the committee yet, or is that still kind of being formed, like what its goal is,
That's what we've been, Adrian, could you move back to the previous slide?
I'm sorry if I missed that.
That's okay. I always assume that when someone asks a question, you're not the only one thinking it, right? So I appreciate the question. So yes, this is the suggested purpose of the committee. And again, it's also described on page 4 of the memo that was sent with the agenda. And so this would be the overarching charge. We assume that when the initial committee comes together, part of what they'd be discussing is who else needs to be part of the committee. There may be subgroups that they suggest. There may be some, you know, sort of structural approaches. We didn't want to take it so far as to presume approaches that might limit what the committee and the community members say is important to do. You see what I'm saying? So overarching purpose, and then we'd pull together the initial group. And I just wanted to comment that Laura Torres added to the chat that she's reached out to many of the groups that were mentioned about Howard County, and she also is happy to reach back once the committee's up and running. And you know, there are certainly a number of groups that have been introduced to the GBRICS idea, and it's a matter of identifying who wants to roll up their sleeves and actually help us figure out the structure and approach to community engagement to accomplish a pretty large purpose, as you can see from the slide.
And I'm thrilled that Laura responded, so that way that means I can work on it with her. So this is great.
It's good.
And then Adrian, this is Sue Doyle from Carroll County. I was just, after our last meeting and we talked about having a meeting of the 4 LBHAs again, I had, and I just found my index card, thank goodness, because I had started writing down some ideas about another project that we had done in Carroll County that was similar to this with outreach to multiple organizations. So I have a pretty good list started here, one of which was LHIC, our LND. Our churches and ministerium have a huge role. We have a Circle of Caring group. So I have all of that. I was actually I had some suggestions and some comments when we met as LBHAs to talk through. So I'll be glad to share those.
Perfect. Perfect. This is helpful. What I can plan to do is to follow, give you guys some time, and then I can follow up with you, Sue, Carl, and Stephanie sometime after this meeting to, get your thoughts on members for the committee. Thank you.
Yeah, and this is Sharon. I think that, looking at the purpose and the activities that you want to do around the Community Engagement Committee, it seems like there's multiple different types of stakeholders, right? So there may be community groups, some come to mind, and then, there's a lot of work. All of our hospitals in Baltimore City, Baltimore County, Carroll County are in the midst of our community health needs assessment. And so there's a lot of groups that have been identified through there. I just can see a lot of opportunity to, you may want to split it up between actual community stakeholders and then maybe some providers and other people who interact with those community stakeholders.
And that's a really good point. And to keep the distinction between who's on the committee and who are the groups that need to be engaged for different activities, right? And then there's also, as you might recall from the overall, the council work plan, there's also funding and an expectation that there will be a vendor that is or vendors that are engaged to help with some, the research or the identification of strategies for community engagement. So it's like concentric circles of activity, right? So at this point, it's identifying who we want to invite to literally come to the table to help shape how this community engagement work might happen. And we want it to be representative